This was a case that came to us, previously managed elsewhere. This was the first study that we had from transferred from the other facility, and it's I think it's just a great urologic case. So a patient came in, had was infected. There's an abscess here, and patient had a stent. So this is why, like, changing stents is really important, and patients really have to be very good about follow up because when you don't follow up and get the stents changed on, whatever schedule, then these are complications of stents that are in the urologic system. So this patient, there's a stent here, and there's a significant calcification that has formed around it. I mean, it's like now a staghorn, and the stone actually extends all the way through the stent and now into the bladder, and there's a stone that's formed around the coil in the bladder. So you're kind of, it's like the complication is worse than probably, I mean, it's just now it's just a big procedure, right? To kind of, and this is complicated by infection, as you can see here. So stents are not benign, and really requires very close follow-up with patients in the health system. And I guess this is a really great case because, like, if you had an absorbable stent, these are less likely to happen, I guess.
I
So
was just thinking, Nelly, they need to come for your absorbable ureteral stent.
then you're done, right? Like, you don't have to worry about all
But
these
this
like
stent has
downstream
probably been in there
complications.
for many years,
Long,
right?
long time. Yeah,
Yeah.
yeah. I mean, now it's like causing significant
I
complications.
wonder if that kidney's even functioning.
Um, there's like
It's
XGP
almost
kind of
like, yeah, I
look,
was going to say, is it XGP? Like the rest of that kidney
yeah.
almost looks like it's got a lot of fluid-filled spaces.
Sure, yeah, right here, yeah,
Yeah,
absolutely here, right? I mean, just from
yeah,
this
that's what it's looking like.
prolonged, yeah, stone that's become essentially a staghorn stone.
Okay, so this is my case. Um, there's the lung bases. There's a finding here.
Well, there's a lot of fat, and where's the pancreas?
Exactly. So it's where the pancreas should be. There's all this fat, but it's not like the pancreas just atrophied away. It's like causing mass effect, right? So fatty replacement of the entire pancreas. And then this is what they're kind of focus on the TI and
Yeah, the
cecum.
bowel lobes. Um, can I see the coronal?
Mhm. I'll just point out one thing, which is that this is the cecum and then this is the TI coming in. So
Mm.
this guy here, as we scroll through, is the TI. You can see it's got like fecalized material
There's a
within
lot of,
it,
yeah,
thickening,
and stool is like
and like the
kind of like a hard
fecalization goes
ball.
all the way over here. And then also the ascending colon has the coronal. So that's my TI there,
Mm.
cecum, all this kind of impacted stool in the ascending colon, and this like fecalized loop of TI. So what would you call that?
Well, cystic fibrosis, we can see that fatty stuff um, in the
The fatty
pancreas.
replacement of the pancreas, you mean?
Hmm.
Yep. And then what do you call
Um,
this, like intestinal stuff?
um, well, in adults, I don't know what you call it in adults. But I know in kids you get that, like, meconium ileus because there's like issues with the bowel.
Exactly. So this in adults is, I think, distal intestinal obstruction syndrome or DIOS. So I'm
Mm.
just going to show you about that all over our Radiopedia. Right. Um, okay. So distal intestinal obstruction syndrome is it's actually meconium ileus equivalent. It's one of the things that we see in adults. It's actually pretty common. It's thought to be in 10 to 15% of patients. And one of the reasons they think is that just basically they don't have enough pancreatic enzymes. So it's patients who have been non-compliant with their pancreatic enzymes. And so they're not digesting food properly. So it becomes like the succus-like material or non-digested food that makes it to the TI. So eventually you get like a fecalized loop in your terminal ileum, and it can cause upstream obstruction. So here's an example from Radiopedia, where you have that like big fecalized loop distally, and then proximally you have a bowel obstruction.
That's awesome.
Yeah. So the main treatment is like basically to get them, back on their, it's decreased in incidence with more microsphere pancreatic enzymes. So we want to make sure that they're on these microsphere ones, and that they're taking their enzymes, and then they can change their diet and things like that. So, and then my patient had like recurrent bouts of colicky pain. So they thought basically they were going like in and out of DIOS. Right now, there's not that much upstream obstruction, but then like a subsequent plain film a couple of days later showed that it was obstructed. So I think they're kind of going in and out of partial obstructions, but you can see like what a long loop of distal ileum is like fecalized here. So even clinically, they were suspecting, and it can affect the right colon as well. And then there's another entity that adults with cystic fibrosis get, which is called fibrosing colonopathy. I did not know about this, but that's actually patients who have been taking like too many pancreatic enzymes, and it ends up wearing away the mucosa of the colon and causing fibrotic strictures. So in that case, you don't usually see all this like fecalized material. You usually just see like stenosis or stricture. And it's kind of the opposite. Like these patients are not getting enough pancreatic enzymes, and those other ones, there's too much enzyme that's hitting their colon and causing mucosal like damage and then fibrosis.
Wow.
Yeah. So DIOS.
So it's just really conservative management, right? Like just bowel
it's
regimen and then
basically
increase their pancreatic like meds.
exactly. They want to make sure they optimize their pancreatic enzymes and then change their diet a bit. Yeah. For DIOS, yeah.
Okay. So this is a patient who was referred to us for pelvic pain. And the finding that I want to share with you is a congenital Müllerian anomaly.
What's all that like cystic stuff in the lower uterus? Is that just normal? Okay, wait. Like all of that, I
And
guess it's just normal.
the cystic stuff, like the stuff
In the lower uterus, I don't know what
in
you're
the
pointing
lower,
at.
oh, sorry, lower
Yeah, right
uterus.
there. Yeah. On the sagittal, it almost looked bubbly.
Here,
Yeah.
let's go back. Let's look at the sagittal. In the lower
Right
uterus.
there. Yeah. Like the whole myometrium
This?
looked bubbly. Yeah.
Oh, I don't know. To me, they look like periuterine vessels.
Vessels. Okay.
Yeah, let me see if I can get the post-con. This is an outside study, so we don't have our typical sagittal sequences. Yeah, they look like vessels. I don't know. What do you think?
Yeah. Yeah. It's fine.
Okay.
You
Wait,
said
I'm going back.
uterine anomaly. All I see is that the
Yes,
uterus is kind of like bent over to the right. Like it's, oh, wait a second.
yes, yes. Bent over to
Wait.
the
So it's
right.
like,
So this is what you're talking about. Okay, what else?
yeah, maybe unicornuate uterus. But then there's a second thing on
Yes,
the left.
yes.
And a
Good,
few
good.
weeks ago, you showed us a case where it wasn't like a rudimentary
Accessory
pain. You called
cavitary
it
uterine
like
mass.
an entrapped uterine mass or something. Yeah.
Yeah, accessory cavity. Yeah.
Cavity.
This is not that.
Hmm. But it does look like there's a second endometrium on the side.
Yeah, like here, right?
Yeah.
So this one, I don't know if
It's like a
let's look at
bicornuate.
P1. Yeah, so this is one, so here, it's not really bright, so that's not helpful there. So yes, so this is the communicating horn right here. So it goes into the cervix, and you have, there's probably, I don't know, there's something going on here too. That doesn't look like a normal endometrium. Um, and then this one on the left, there's one there too. So this is actually, but this one doesn't communicate with the cervix. You can see that it's separate. So this is a case of bicornuate uterus with non-communicating horn.
Cool. And then they both have this weird junctional zone abnormality, but I don't see
Yeah.
spaces. Like, would
Yep.
you call
Yep.
that maybe adenomyosis or?
I would raise it. Yeah. Like, so that's actually a known complication. Um, it can endometriosis, right? Like this is not this one. I think they both have it, but patients like with the non-communicating horn, it can increase the risk of endometriosis and adenomyosis if it, goes into the myometrium.
Which makes sense because it's like it's not able to drain out, so it's kind of
Yep.
gross into the myometrium.
Yep. Exactly. So the patient came to us for deep endometriosis treatment, and there's like plaques, so there's probably DIE, deep infiltrating endometriosis. Not big ones, but yeah.
Cool. Do you know what they're going to do about this, the other horn?
If it's symptomatic, they usually resect it. They resect the non-communicating horn if it's, causing problems. And
Yeah,
it's
and it
usually
looks like it's probably
points.
functional endometrial tissue, so there's an increased risk of malignancy, so they probably need to.
And they can also increase risk of infertility too. I didn't realize there was an increased risk of malignancy, but I know that infertility is an issue. Can be an
Yeah,
issue.
the non-communicating horn can, because like you're having all this endometrial proliferation without an efflux, like without a root out, So like over time it gets inflamed.
Well, that makes sense.
But
Oh,
okay,
then they get that clear cell stuff, right? The clear cell carcinoma.
maybe I know
Or that from
endometriosis,
endo.
endometrioid cancer, and clear cell cancer. Nelly, quick question. You said increases infertility. I thought if you have a bicornuate uterus, but one of the horns is okay, you can still have like a regular pregnancy in that horn.
Yes, if one of them fallopian tube is fine. But endometriosis, can lead to fallopian obstruction, tube obstruction.
Okay.
Not
So not
necessarily.
just from the bicornuate, but
Mm-hmm.
because there's this obstructed thing and then there's
Yeah.
endometriosis. Yeah. Okay.
Yep. Yep.
Okay. So what do you guys think about this pelvic MRI? So prostate
Mm.
looks a little not seeing much zonal anatomy.
Yeah, it's kind of diffusely hypo. The right seminal vesicle is abnormal, it's dilated. You lose the normal ovulations. I don't know if the patient had prior infection or something, or is obstructed maybe.
Good. So it looks like an obstructed
Um,
seminal vesicle on this side. And then what about this side? Do you think it looks normal?
no, the seminal vesicle is decompressed. There's chronic changes of like chronic decompression or obstruction or something. I don't know.
Okay. So we have like one that looks atretic and like atrophic and one that looks obstructed. And then I'm going to give you the clue.
The
So wait, lung base is here. There's some findings.
yeah, like cystic fibrosis.
Yeah. So this is my a companion case to the one I just showed you.
Oh, it looks
Again,
just like your other one.
exactly, but this one does not have DIOS. But anyway, this one he has some bronchiectasis and cystic changes at the lung bases, complete fatty replacement of the pancreas, and then there was these findings in the pelvis that triggered the MRI. And so the MRI showed, like I showed you, that there was like one obstructed seminal vesicle and the other one just looks like really atrophic and they don't look normal. So anyway, I didn't know this, but cystic fibrosis can lead to seminal vesicle agenesis and also obstruction. And actually, if you have bilateral seminal vesicle agenesis, that's almost only seen in cystic fibrosis. I think it has to do with the secretions that the seminal vesicle makes or holds is like related to the whole enzyme thing with cystic fibrosis. But anyway, just remember cystic fibrosis can also affect your seminal vesicles. It can cause infertility because it leads to agenesis, and sometimes like that agenesis leads to sort of like one big obstructed kind of gland. It's just another complication of cystic fibrosis.
Cool.
You can go.
Oh, this is a patient who had liver transplant, and the MRI, the first or some of the earlier MRI after the transplant looks like this. So there's obstruction centrally with upstream biliary ductal dilatation. Patient was treated with ERCP. and then follow-up imaging. Patient has several ERCP, dilatation, and here's obstruction here essentially. And then now the patient is stent-free. So it's gotten much better over time. This is the most recent MR. And so they're still narrowing there, but patient no longer narrowing there, but no longer requires stent. And LFTs have improved.
Millie, I have a
So
question. You're
yeah,
showing two different, like that's the anastomosis right there,
here,
right?
and then the stricture is right here. Sorry, yeah.
Okay, so it's
It's
not
here
an
somewhere.
anastomotic stricture. It's like there's some like
No.
weird soft tissue around.
Yes.
And so I'm
It's
thinking
not. Yeah, it's like
PTLD.
one more time.
PTLD.
Oh no, this is sorry. This is not PTLD. But although PTLD is a great um, consideration, this is
Then I want
just
to see the
one
hepatic
of the
artery.
subtype of hepatic arteries patent. Let me give you the hepatic artery. I think I have a
So
CT
whenever I
here.
see like biliary issues post,
Yeah,
I want to make sure the
here,
hepatic artery is fine. So it's not
here I
biliary
have a.
ischemia.
I have a venous. Let me see if I have an arterial somewhere. All right, it's okay. I'll just show you venous for now. Hepatic artery was fine. So here's the right and left, and then maybe here,
Yep.
right there. Oh, this is not a good one. Let's see if I
Okay, I
can get a
believe you.
better one. On the MR, here. Okay, so here's the right and left, and then there's the common hepatic. Here maybe, and it goes somewhere. Actually, I have a hard time following it. I don't really see it, but the the concern or the issue, so this was felt to be cholangiopathy, ischemic cholangiopathy, following DCD liver transplant, and I wanted to share the classification with you. There's 4 different patterns of cholangiopathy, and this is DCD cholangiopathy, like it's not related to hepatic artery thrombosis. This is just from cold ischemia time being really long and leading to biliary ischemia. And so there's 4 classifications. This one is the central confluent dominance type, normal post-transplant, and then you can get the diffuse necrosis. These almost always require retransplantation, and that's why it's important for us to kind of recognize this. It can start as multifocal mild and then progress to diffuse necrosis. And these, again, also require retransplantation almost always. The confluent dominant and the minor form can be managed conservatively with just ERCP and stenting, and often do not require retransplantation. So there's a Kaplan-Meier curve. This one, is that right? Yeah. There's one somewhere. Here it is. That stratifies by the 4 different types of DCD ischemic cholangiopathy and time to retransplantation. So the multifocal progressive, that's this orangey one, and the diffuse necrosis, that's this kind of burgundy one, almost always require retransplantation, whereas the other 2, this case was a confluent dominant type, and then the minor form can often be managed with ERCP and stents. So our transplant team, like we try to classify the cholangiopathy for them if we recognize it and see it, because it has like prognostic implications.
Nelly, you showed that paper before,
Yeah,
and so glad you showed it again because I completely forgot about this entity. So repetition is key.
100%.
Yeah. Okay, so this was a patient with, obviously you can see cirrhosis. Maybe there's some non-occlusive thrombus in the portal vein here. And we saw
Up
this
there.
lesion. This was a single phase. This was being done for abdominal pain. So saw this lesion here, said, it's got very avid globular enhancement peripherally that's following blood pool like the aorta. This could be a hemangioma, but there is this like geographic perfusion abnormality distal to it with some atrophy. Not sure what's going on here. Get an MRI. Do you guys feel like you see any other findings?
Right there. Up, segment 7 up high. There.
This?
Yeah, up high. Yeah, a little bit more. One more slice. There.
Okay, good.
Was
So
there
maybe there's
any other
something
lesion
there.
in the left lobe?
Lesion in the left lobe. There's some weird perfusion here.
Yeah, maybe perfusion.
Okay, so we recommended an MRI. And here's the T2 on the MRI.
Ooh. Oh my gosh.
So that little thing that you saw, Nelly, this is just like them. I think the MRI was.
Wait, did it just
days
progress
later.
like so fast? Like, or
No, this
what
was
was it?
3 days later. I think this is just
Oh.
how CT sucks when it comes to.
Oh.
So let me show you the diffusion.
Oh my goodness. It's
So there was a very extensive infiltrative HCC. And actually that like that, that lesion over there with that was just like a red herring. Like it wasn't even the main finding. And there is something in the left lobe as well. Not super, super impressive on ADC, but it's there. And arterial phase kind of not that great, but I will show you. Delayed phase also not that great, but it's involving that portal vein. So I can convince you. So it's just this very large infiltrative lesion here, for example, and the portal venous flavoids are out. And if you go back to the CT, we saw like, there was this little heterogeneity here, but all of this area was all tumor. And in retrospect, you can see that not only is there bland thrombus in the portal vein, but there's something else here. And it's taking out this entire posterior division.
yeah.
Right? But that's just blending in completely, or like this superior aspect of the posterior division. So anyway, it's just blending in completely with the liver. So anyway, just another kind of scary example of, I feel, infiltrative HCC can easily be missed on CT, and also, especially if you only have one phase, but also on ultrasound as well. So if you see any kind of really heterogeneity, anything suspicious, have a low threshold to get an MRI.
That's crazy. Wow. I mean, that's why MRI is so much better.
Yeah. But I do feel like also in retrospect, sometimes we'll be like, oh, wait, there's something missing here. We got to look really, really carefully at these portal veins, So anyway.
Yeah, infiltrative SCCs are real tricky. They don't enhance like your other typical HCCs.
Yeah, and diffusion really, really helps you.
Yeah.
Because a lot of times they don't even necessarily induce angiogenesis, so they don't necessarily have the typical arterial enhancement washout.
Correct.
Here's a good example of another great example of MRI and how it's so awesome. So this is a patient it's a single phase study, and there's this like heterogeneous area up here in the upper pole. Here's the right there. And it looks obviously abnormal, and it could be a host of things, including RCC. So then we got MR, and MR, we can see that there's intrinsic T1 hyperintense signal. And but then if you look at the post, here's a subtraction. Here. You see that this part is hyperintense, but this part is not. And on the arterial phase, that enhances the hemorrhagic part does not. And then you can see that nodular enhancement on the subtraction again as well. So, just another example of how MRI can be so helpful for characterization and just, increase conspicuity and just overall improve character, not just for liver, obviously, but for kidney. And that's why CCLS is, designed for MR and not for CT.
Yeah, I love this case. Actually, your subtractions here in the bottom left are actually really nicely registered, but oftentimes the kidneys, like, they're not registered, or there's like a big hemorrhagic lesion and you're like, is there truly an enhancing component or not? And what I like to do is what you did above, which is like put the T1 pre and the post right next to each other.
Yep.
See, like, what are the areas that now look bright that weren't bright before, right? Like, and where are the filling defects on the pre-contrast that now we're filling in?
And sometimes you can have low level enhancement and you need that side by side of the, the pre and the T1. Otherwise, it's just so hard to tell, like, on the subtraction.
Yep. And in that CCLS algorithm, they actually say that you can use the arbitrary units. So Hounsfield units doesn't work on MRI, but if you put your measurement on it, it's called AU arbitrary units. And you can see if it's going up by more than 2 standard deviations and use that 2 standard deviation rule to say, I think this is true enhancement.
Mm.
Okay, so this is my case. Oops. Keep trying to take the markings off. Okay. So you can see that they've got a AAA. What else do you guys think? I can show the coronal in a sec.
So there's something encasing the left renal artery. It's like essentially hypoattenuating. And then there's this rim around it. The vessel itself looks patent. I don't,
Irregular.
is there an aneurysm? I don't know.
No,
There may
it looks
be.
like the aorta and the vessel there are
Okay.
relatively normal.
Hypoenhancing.
Yeah. And there's this
Pancreas.
kind of,
Oh, good. Just checking the pancreas, see if there's any other weirdo spots elsewhere.
pancreas looks fine.
In my mind, I was thinking IgG4, other weirdo stuff, lymphoma, infection. Like, I think the vessel. I mean, I was like, could it be like a, pseudo? Like, I think aorta is the aorta okay? I mean, do we lose the wall? Is it infected? Like aortitis?
Good thoughts. Yep. Wall looks okay so far. And Tarun, you were going to say something?
No, how's the contour of the renal artery? Do we have like angios or something? Like, is there something?
There's no
Is there
aneurysms. It's
yeah,
still
that's what I was
patent.
thinking.
Looks okay. But I will point out something that I think is really easy to miss. And I've missed it before. So you can see that there's some asymmetry in the psoas muscles here. And there's
Right.
actually a psoas abscess. And so psoas abscess and hematomas, I think, are kind of easy to miss. I'm going to show you on the venous phase. So that was the arterial phase. Here's the venous. It's still easy to miss if you don't look there, right? But the asymmetry kind of tips you off. And then if you now you can start seeing that there's this rim enhancing thing. And if you go to the coronal, it's even it's more dramatic, right? So rim enhancing collection in the psoas. And then we've got this rim enhancing collection encasing the renal artery. And then and the kind of phlegmonous stuff here. So we actually thought this was like basically an abscess. And turns out the patient has MSSA bacteremia. And whenever you have, so it's not like a traditional mycotic aneurysm and that the aorta contour is still normal, but it's an abscess encasing or abutting the aorta and encasing branches of it. And you always have to go look for like a source. So we're looking for like osteomyelitis discitis, which in this case we don't really see here. But so anyway, this patient with a bacteremic, they had a psoas abscess, and then we think that they basically seeded their aortic, like periaortic space. So even though it's not a mycotic aneurysm yet, it's basically an abscess that's like bathing the aorta and the renal artery.
Wow. So how did it
And I think,
come to
oh,
that
go ahead.
psoas? Was there anything in the nothing disguised? Was MR done?
No, I don't think an MR was done yet, but it wasn't. No, from bacteremia, you can just get psoas abscesses. I've had several cases, even of actually people I know, where
Mm-hmm.
they've gotten a spontaneous psoas abscess just from bacteremia. So the same way I feel like you can get these spontaneous psoas like bleeds, like hematomas from like if you're hypercoagulable. I just feel like maybe there's some friable blood vessels or like milieu there that can seed the psoas muscle, but it doesn't always have to come from like osteomyelitis.
I think
Okay.
the other is that the nomenclature, we say mycotic aneurysm, but I thought that was like is that the old naming? Like we're not supposed to use that anymore? Is that right? Or
Oh,
like,
I don't know why. I know I can see why it would be renamed because mycotic is sort of like mushroom and it's not like a fungal infection. It's basically just meaning that the aneurysm becomes mushroom-like.
yeah, yeah.
But I don't know the new name.
I mean, I think it's just like infected aortitis or
Oh, got
infected
it, got it.
aneurysm, just so that's clear. It's exactly what you're saying. The word mycotic is misleading.
Yep. And I've seen mycotic aneurysm. So normally, there's several predisposing things that can give you infection of your aorta. So either just discitis, osteomyelitis, or if you just have like a AAA with thrombus, because like if you're bacteremic, it loves seeding the thrombus, it loves eating the thrombus and like seeding it. And then that can just lead to infection and then breakdown of the wall, which leads to this kind of lobulated fungating appearance. This was just a little different in that the wall looks intact and it's kind of like an adjacent abscess that's now just kind of like probably going to eventually erode the wall. But yeah, anyway, this was slightly different. The other thing when they say you have gas, if you have gas in your in your AAA or aortic wall, you should always look for a colon cancer because when colon cancer breaks down the mucosa, there can be bacterial translocation of like strep bovis and E. coli, and that can eventually get to the aorta. Okay, patient, just like no history, came in with abdominal pain.
Ooh, oh my goodness. So
Just like
multiloculated, large hepatic process, and there's maybe two of them.
Yeah, so there's like this one, like maybe a little mushroom
Yeah,
component here, and then a
back
couple more.
there. Yep, lots
Did
of
you say?
inflammatory changes.
and then
And then
portal vein is
there's
thrombosed.
right there. Yeah, right there. Yep. Something
Okay,
is
good.
something
And
there.
so
I
one
don't.
of the clues here for the
Um,
trainees out there is the hepatic arterial buffer response. So whenever you see this geographic area of hyperenhancement, that if it's geographic and it's brighter than the rest of the liver, that should clue you in that something might be wrong with the portal vein and the hepatic artery is taking over. And in this case, we've got this whole geographic area, but it's because that right portal vein is out. So I just showed you guys that case of the like infiltrative HCC with tumor thrombus and stuff. So is that what you think is going on here or what's going on here?
I lean more towards
infection,
infection.
Yeah, yeah, yeah.
abscess.
Good, good, good. So yeah, so this is infection. Although the liver looks a little abnormal here, this looks much more like a multilobulated inflammatory process, ill-defined borders. So this was a huge hepatic abscess. The abscess itself can cause hyperemia around it, but also because these infections often come from the GI tract and flow up the SMV and portal vein, they're often associated with septic pylophlebitis or infected thrombus of the portal vein. So we have pylophlebitis, we've got that perfusion abnormality, and we've got a large multiloculated abscess. And then this is what we call the cluster sign, which is like that there's little smaller abscesses along the edge that haven't sort of become confluent in this more liquefied abscess here. And that happens because basically the bacteria comes up through the portal vein and then showers often the right side of the liver, and then finally it coalesces. So it doesn't look like a real mass with, a border. Although, infiltrative HCC doesn't necessarily have a border, but this looks much more inflamed. It's got like all this phlegmonous tissue around the edge of it. And this was a big abscess. So we
What was the back to
Oh
like
yeah. So
the
anytime you see an abscess, you should go look for a GI source or source in the abdomen. So we went down and looked, and what we saw was actually the abnormal thing was the TI here.
Mm.
there's like a
It looked enhancing,
thickening and
thickened, enhancing. There's like little hyperemia around it, lymph nodes, almost like speculation.
it looked like
And
a
we even
mass.
brought up IBD because it almost looked like a tethering, like fistula formation.
I think
Um,
you also have to rule out a mass.
Yes. Okay. So anyway, they did a colonoscopy, they intubated the terminal ileum, they saw this inflammation, and they biopsied it, and it came back like severe inflammation that was they thought was related to like a drug reaction. And turned out this
Oh,
patient had a
really?
history of cocaine use.
Mm.
So I don't know exactly what happened, but my theory is that the cocaine use caused like an inflammatory enteritis. And then maybe some of the bacteria kind of, because it was so inflamed, it got into the bloodstream and then caused the liver abscess.
Wow.
Wow.
Yeah. So very interesting. But you always want to rule out. So this is the appendix here. So it wasn't from an appendicitis. There was no diverticulitis. So like other causes. But I will say a lot of times, I think maybe up to 50% of these liver abscesses, they call cryptogenic in the end, because like by the time the liver abscess may be smoldering, it can be like really, low grade kind of pain. By the time you go back and look at the GI system, it might the original culprit might have already resolved. So a lot of times we don't get the final answer. In this case though, there was this like abnormal TI. So yeah. And then let me just show you beautifully drained by our colleagues. So drain in the big locule, and it got just smaller over time and did well.
What did it grow?
I don't know. I can look that up.
Okay. I was thinking about that turquoise sign that we were talking about before.
Wait, the turquoise sign, remind us again, is for
Klebsiella.
Klebsiella. Right. Okay, I'll look it up while you're
You
sharing.
get the infected thrombophlebitis with that too.
Yeah, but I think that can happen from other.
Yes.
Yes, not specific.
Yeah, bugs. History withheld, prostate MR.
So it looks like a really extensive T2 evil gray mass that's involving the seminal vesicles, restricted diffusion, bubbly kind of going. It's like blobby and bubbly. It's like my first thought was like lymphoma. And then
Good. Yeah. Yeah. So this patient has a history of it's like hairy cell leukemia. Hairy cell leukemia. Unresponsive to multiple chemotherapy regimens. And this is felt to be manifestation of from that.
And was there other adenopathy elsewhere?
Maybe here a little bit. Not, I don't see any in the upper images. Yeah.
It's weird that it just picked that spot.
Nice.